Welcome back, everyone, to Diversion Insights. Today, I am joined by a returning guest, Dr. Stuart Gitlow. For those of you that may not have heard our previous episodes together, Stu is a partner and chief medical officer at Limitless Ventures, a past president of the American Society of Addiction Medicine, and he maintains an active private practice as a psychiatrist specializing in addiction medicine. Today, we are tackling what has turned out to be one of the most controversial topics to emerge from listener feedback, and that is treatment with buprenorphine, naloxone, most well known by the brand name Suboxone. I have received several comments from listeners who have had personal experience with this medication. Comment after comment described how poorly they felt while taking it, and even more concerning, how difficult, seemingly impossible, according to their comments, that it was to stop once they started. And what really struck me was how many said they wish someone had told them this up front before they began treatment. So these are real people that shared their experiences with me, and it made me realize there might be a gap between what patients are being told going into treatment and what they actually experienced. So I reached out to Stu because if anyone can help us understand both sides, it's him. He has successfully treated over 1,000 patients with buprenorphine since 2011. So today we're going to dig into it and the science behind it, the patient experience, the challenges of discontinuation, and what people really should know before starting treatment. So Stu, welcome back to the show.
Thank you very much. Happy New Year.
You too. I want to start with something that you said to me previously, and that is, quote, from an email that you sent. People have to realize that addictive disease isn't about the drug. It's about the discomfort that folks feel with the illness when they are not using. These individuals discover that opioids, in the case of opioid use disorder, helps them feel better. Unfortunately, opioids have a negative effect. As they wear off, the user feels worse than in the first place. This leads to the endless cycle of increasing use. So let's expand on that for us a little bit.
Sure. To expand on it, one has to go back and figure out, why do we have addictive disease? What is the disease itself? We tend to define the disease based upon behavioral factors that we can see. Somebody is using a drug, quote, too much, and getting into trouble as a result of their use, and then returning and using the drug again, despite the fact that they've already proven to themselves that each time they use the drug, they get in trouble. That's a very different scenario than an individual who uses a drug from time to time, never has any difficulties as a result, and just goes through his or her life using the drug in that manner. So those are two different stories, two ways in which an individual might use drugs. One is seen as a social decision, a lifestyle choice, if you will, and the other is a factor that is used to identify the presence of a disease state, right? If I'm holding my finger up and I light a match under it and it burns my finger, I don't tomorrow say, let me try that again and see if it'll have a different effect.
Right.
I should learn from the experience. Folks with addictive disease don't learn that. And as a result, you have to back up and say, well, what was wrong with them in the first place that led to their repeatedly making a bad decision when they don't make bad decisions in most other aspects of their life?
Okay.
So that disease is addictive disease. It's what we call addictive disease. And it obviously exists before the individual ever picks up a drug in the first place. What is that state? It is typically a state of discomfort. The individual does not feel good. So that the very first time they use the drug, be it alcohol or opiates or marijuana or whatever, the first time they say to themselves, I feel better as a result of that. That's not what most people say. Most people who use alcohol, for instance, as a social activity don't say it makes me feel better. They say that makes me feel different. But an individual with an alcohol use disorder goes, wow, this is the way I think everybody else feels most of the time. And they're correct. That is the way most other people feel most of the time, just not you. So we get these folks who are on the outer 10% in terms of how they feel. They feel this vague sense of discomfort. The world is too noisy, too loud, too hostile, too irritating, too bright. And when they use for the first time, they feel better. Now, all that means is that they are now off to the races and trying to chase the improvement that they got the first time they used the drug. The problem is that each time you use a drug like an opioid, you end up with the brain having a rebound effect where you feel worse for a longer period of time than you felt better from the drug. So the drug might make you feel good for 2 hours, but now we've got 8 hours where we're not feeling good at all. In fact, we feel worse than we did to begin with, which was already kind of uncomfortable, right? And the longer you take the drug, the longer the period of time that withdrawal will take effect. And even at the end of the withdrawal, you're left back at your baseline, which was uncomfortable. The difference between then and now is now I know what will make me feel better, if only temporarily. So that's the critical part about the disease. We don't think about the disease as in we're trying to get you clean and sober. Clean and sober is merely the point where I can start treating the disease. Clean and sober just means you're no longer doing anything to treat your baseline discomfort. Now it's my turn to come in as a physician and provide some treatment that will actually work.
Okay. Now, that description that you gave was great. Is that the reason why, when it comes to the healthcare setting for healthcare professionals that have an opioid use disorder, why we can often miss some of these signs at the beginning? Because as long as they are medicating themselves, they are at now their new baseline for performance and they can continue to perform. It's when they're in withdrawals that we may start to actually notice there's an issue.
Essentially, yes. I mean, realize that opioids work the same way whether you have opioid use disorder or not. If you take a specific dose of an opioid, whether it's heroin or Demerol or oxycodone or whatever it is, if you take the same dose every single day and you take it in a safe manner, right? You're not buying it on the street where it's mixed with who knows what. But you're taking a prescribed dose consistently, you generally will not have any limitations. There generally won't be any abnormality that will be apparent to a bystander.
Okay. Right. But if your needs have escalated to the point that you're taking more, but that becomes your new baseline, so you can function under that as long as you have it.
To a point, yes.
Okay.
I mean, right. That works right up to the point. The risks with opioids, everybody talks about opioid overdosing. The opioids, unlike alcohol, unlike cannabis, unlike really all the other addictive drugs, is not toxic to any of the organ systems. So if you took an opioid every day as prescribed, an appropriate amount for years and years and years, and then stopped by tapering it off, and we analyzed your organ systems, was there any damage due to the opioid use? Typically, the answer is no. Unlike, say, alcohol, where there's damage to multiple organ systems. So the risk with opiates comes with the overdose. In other words, you use such a dose that you stop breathing.
Right.
And if you don't stop breathing, then there's no toxicity.
Right. Okay. Yeah, that makes sense. I think people have a hard time thinking about the fact that they could be working alongside of a peer who has an opioid use disorder and is using, a substantial amount at this point, but they're appear to be fully functioning cognitively.
Let's separate those out, because
Okay.
they could be saying that, let's say I've got two people on either side, both using the same dose of an opiate.
Okay.
One does not have an opiate use disorder. They're simply taking the medication as prescribed for their, say, cancer-related pain.
Okay.
There's a reasonable reason to be taking the medication. Let's say the cancer without the pain is still allowing you to work. You can still do what you would like to do. And you're taking the medication consistently, so you're not going to have any noticeable limitations from that. And so you're able to do your work. Then we've got the guy on the other side. He has opiate use disorder. He's also taking the exact same dose. He's no more dangerous today, but the problem with opiate use disorder is that they tend to chase things. They're not taking a medication as prescribed. They're mixing it. They don't know if today's dose happens to have fentanyl in it or not. They don't know if today's dose happens to be more concentrated than yesterday's was. And they don't know what they're going to get as side effect. So the results of the illicit use end up being problematic for that reason.
Right. Unless they're taking it from their workplace. Then they know consistently what they're getting.
Right. And in which case you have other issues. Perhaps they're stealing it from patients, or they're taking it from the pharmacy card, or something else which will have secondary effects.
Right. But we could also assume that they're going to continue to chase it, and their dose is going to build up over time. So they're not going to be even anymore. This person is going to escalate. Correct?
And that's why we'd like to find them and get them to treatment sooner rather than later.
Right. Okay. That makes sense. Okay. All right. Let's talk about buprenorphine. How does it work? Why does it work? Difference between buprenorphine naloxone. When would you use one over the other?
Yeah, let's talk about definitions here for a moment.
Okay.
Buprenorphine is what we call a partial agonist opioid. In simple terms, essentially what that means is that, unlike an opiate like heroin, buprenorphine has what's called a ceiling effect. You really, if you're taking it by itself, you can't take enough as an adult to get respiratory depression. You can't overdose with it as a result. So even if you try to take more to get more of a feeling from it, if you're chasing a feeling with it, it's not a good drug for that. So it is not as good as heroin in terms of wanting to get a level of intoxication. So it won't do that. Now, if somebody comes in who's never used an opiate before in their life and they take buprenorphine, yes, they would feel something, but they're still not going to be able to overdose with it and die from it. The only way they can do that is by mixing it with other drugs. And so it's not due to the buprenorphine itself. Naloxone is an opioid antagonist. The bottom line for that is we mix it with buprenorphine that's taken sublingually by placing it under the tongue. Naloxone is not absorbed under the tongue. So you ask, well, why is it there? It's there to make it so that if somebody misuses the buprenorphine by, say, liquefying it somehow and injecting it, they will then get the effects of the naloxone, which an opioid antagonist counteracting the effects of the buprenorphine and therefore making it so the drug doesn't do anything of particular interest. So you wouldn't want to use it that way because the naloxone is there. But the way it's taken as instructed, buprenorphine, naloxone, and pure buprenorphine are the same because the naloxone simply isn't absorbed that way. So Suboxone is the brand name for the combination drug. The old brand name, I don't even think it's made anymore, is Subutex for the mono drug, just the buprenorphine. But bottom line is that Suboxone or its counterparts, other brands like Zubsol, are the drugs that are the combination drugs.
Okay.
I've been asked many times, aren't we just replacing one drug with another? And The answer to that question is yes. Of course we are. You have a person on the street who's trying to address their native discomfort with a drug that can potentially harm them through an overdose or through any of a number of other things and is illegal to boot. Um, or they can come into a doctor's office, get a much safer drug that doesn't have any of the negative implications, that isn't illegal for them to use, and which also helps them feel better. It's using much of the same physiologic mechanism that any other opioid would, but with that ceiling effect, so it prevents them and protects them from harm. So yes, we're replacing a bad drug with a much better drug that they can then stay on and deal with their discomfort. But it begs the question, well, do I have to take this forever? And the answer to that question, a lot of people will argue it. I'll make it really simple. Yes, you have to take it forever. And the reason is, just like you have to take your statin for your elevated cholesterol forever, just like you have to take your antihypertensive for your blood pressure forever, the addictive disease is a chronic, lifelong condition. Can I get you to a point, like I could say with through diet and exercise, where you don't have to take the medication every day? And maybe, and maybe for a little while, but it's not going to be permanent. You'll eventually probably need to be back on the antihypertensive. You'll eventually probably need to be back on the statin, and you'd eventually probably need to be back on the buprenorphine. The reason for that is that you have an underlying condition that caused you discomfort in the first place. Unless you learn new coping skills for dealing with that discomfort, you're always going to hear that cry in the wild that says, there's this drug that will make me feel better, if only for today. And Suboxone or buprenorphine in general will make it so that you don't hear that call. You're able to go about your day-to-day work and never even have to worry about it or think about it. So that's the question. You can go to AA, you can work the 12 steps, you can have a sponsor, you can get into a recovery program and work very hard, just like people with alcohol use disorder do, and get to the point where your coping skills are good enough to deal with this on an everyday basis. And if you do that, you could come off the buprenorphine. But if you're not willing or interested in doing that, you can stay on the medication, and that will address the bulk of the issue. You still might have difficulties interacting with other people, being sociable, finding ways of expressing your feelings. There's still going to be difficulties with that, because that's a classic finding in people with addictive disease. And that can be addressed through the 12-step process. But if you don't want to do that, and you want a quicker fix, if you will end up in a situation where medication will get you to the point where you can get your life back, and then make a decision as to whether you want to go the full extent of the treatment process.
Okay. So is your usual approach to put somebody on the buprenorphine and then work on the other things with therapy, the coping mechanisms and those types of things?
Right, because buprenorphine has one other aspect of it that makes it safe. It is very sticky once it is taken, meaning it adheres to the opioid receptors with great strength. So if I take a street opiate while I'm also taking buprenorphine, the street opiate will not have the same effect it would otherwise. The potential for it harming me is lower as a result. So not only am I taking a drug that won't hurt me directly, but it's protecting me from street drugs. Not all of them, right? If I take a particularly strong fentanyl or something along those lines, that can be even stickier than the buprenorphine. So it's not a fail-safe, but it will certainly protect me from the bulk of what's out there in most places. So yes, I start on the medication. Now my patients can consistently get a medication that is helpful to them. that will allow them the comfort of knowing that they don't have to be buying something that's illegal from people doing things that probably aren't nice, and getting into all kinds of trouble as a result.
Right.
The benefits abound. But yes, I am trading in one drug for another, absolutely. And it's funny. Years ago, initially, I said, "Oh no, that's not what we're doing." Yes, it's exactly what we're doing.
Okay. All right. Well, I guess, I mean, and I'm assuming you tell your patients that up front. Yeah. Okay. What is your recommendation if one of your patients does find themselves needing medical treatment in the hospital, needing pain medication? What does that look like for them?
Happens all the time. Buprenorphine happens to be pretty good at addressing pain. But as you might guess, once a person is taking it every day, they grow tolerant to it. And the typical approach is to increase the dose. But remember, buprenorphine has a ceiling effect. And so it can only work so much. I tend to dose at around 16 milligrams a day, which gives me some wiggle room. You can actually keep going up 24, 32 milligrams, and that will generally address pain. So I've had folks go through significant surgical procedures. I recommend to their surgeon usually that the buprenorphine dose be increased to either 24 or 32. We do that for a period of time. Whatever it is that the surgeon says, now it would be the time I would normally taper them off, I bring them back to the 16.
Okay. All right. All right. Let's say somebody starts on it. They've done the work. They feel like they're ready to see about weaning off of it. What does that look like?
So most patients will, remember that folks with addictive disease have, as part of the disease, a desire to have something fixed immediately. Their tendency as a group, if I can stereotype, is to say, I'm not willing to wait to feel better. I have to feel better right now. So when they make the decision to come off the medication, they will typically stop the medication and tell me later. Then they get very uncomfortable and they come in and they say, well, I wanted to get off, so I stopped. And it was horrible. And I never want, yeah, of course it was. You stopped an opiate, suddenly you're going to feel awful. This is a drug which needs to be very, very gradually tapered off. And very gradually is much more gradual than any patient would automatically assume. So if I have somebody on 16 milligrams a day and they're taking that for a few years, which is usually the point where they would like to start coming off it, then I will bring them down to 8 milligrams quite quickly, and leave them at 8 milligrams for at least a month. Then they go to 4 milligrams and they stay there for at least a month. Then they go to 2 milligrams and they stay there for at least. So already it's 3 months and we're still not off the medication. But that's the only way to do it comfortably. Some people, it's got to be 2 months at each step instead of 1 month. And the most difficult part is getting to stop those last couple of milligrams.
Okay.
So that's part where I generally tell people that the full taper is a 6-month process minimum. It might even be a year, but 6 months is going to be an absolute minimum. And then you might say, I can't do it for whatever reason. There are many reasons why somebody might say that. So I have a number of patients who are taking 1 milligram or 2 milligrams a day.
Okay.
And they say, yep, I feel better than I did when I was taking the 16 and better than I do if I'm taking that. And they're comfortable with that.
Okay. What about, I've heard post-acute withdrawal symptoms. Can you talk about that? Is that just during that taper process or when they try to just stop cold turkey?
Post-acute withdrawal syndrome, some of you will see it as abbreviated as PAWS. And it is basically it's a bucket that people put any symptom that they're experiencing outside the 3 days after they stop the medication or the drug that they've been taking.
Okay.
Unfortunately, they're missing the boat with that term because it includes a lot of things. One thing, the most important thing that it includes is the baseline level of discomfort that the person had to begin with before they eat drugs. So it's not withdrawal at all. It's addictive disease, and it's demonstrated through the person's sense of depression or anxiety or irritability or sleep problems or whatever it might be. So whatever your baseline was, that's not withdrawal, that's just addiction. The second thing they confuse it with is it's not post-acute. It's still acute. It's just that acute withdrawal after long-term use can last 12 to 18 months. So, for instance, sleep doesn't return to normal after alcohol use disorder has been addressed, right? After you first get sober from alcohol, it will take a minimum of a year for sleep to return to normal, and usually close to 18 months. That's not post-acute withdrawal. That's withdrawal. It just takes a long time. So, depending on the dose and the duration for which somebody used, withdrawal can last at least a year. That is not at all unusual. So I look at people and I say, listen, for the next year, I want you to be as stable as possible. Now, we're not even going to think about stopping the buprenorphine if that's what you want, if that's what you're on. If you had alcohol use disorder and you're in early treatment, we're not even going to start to address the rest of your life until we get through the first year. We're not going to use medication to address symptoms. We're not going to fix your sleep. We're just going to wait and let your body work its way through. And it will. It takes time.
Okay. So if somebody goes through the buprenorphine, the therapy, addressing everything that got them there in the first place, they decide they want to go off of it, they taper down appropriately over that 6 months to a year, whatever it is that works for them. And then they get to zero. They choose to go to zero, not stay at the, 1 or 2 milligrams. They choose to go to zero.
See?
They may still feel uncomfortable. They may think it's PAWS, but it could just be you're back to the baseline that got you in trouble in the first place, where you're not feeling well, and or the rest of your body is now catching up to being without any medication at all in terms of your sleep and that type of an adjustment. Am I hearing that correctly? Okay.
Correct.
So, yeah.
Yeah, I mean, there's a third set of factors as well, right? A person's life is usually a mess at this point, right? They've run out of money. They don't have a place to live. They have no job. Their family has left them and doesn't want to hear from them. Their car's broken down. Everything is just a calamity. And they have to try to put the pieces back together. That's not a scenario where most people wake up feeling happy in the morning, right?
Yeah.
And so their life is one of, regulatory burdens and hurdles and just trying to figure out where am I going to eat and how am I going to sleep this evening? Let alone the fact that I can't even get to sleep, even if I have a good bed and even if I've had a good meal because I feel terrible. So it's not a conducive place to say, don't worry, you'll feel better soon. So all of that has to be taken into consideration.
That it almost seems actually like a good point. I mean, do you to have a patient who's like, all right, I'm ready to stop. I would almost think that the advice would be, if you've got all of these other things still going on, let's not do this right now. Let's wait. Let's wait until you've got your life back together. You've dealt with all of the legal issues, if there is, your family life is back to being stable, or at least you've adjusted to now your new life, before you even and continue with your therapy before you even begin the taper down and stopping that buprenorphine.
Precisely. And
Yeah.
that's something where I want all other variables to be going.
Yes.
That I know if the taper is working or not working and what we're going to do as we progress. Because, the bottom line is I don't want the patient taking a medication if they don't have to. and neither do they. But this is a chronic illness that progresses even in the absence of use. That's the other aspect of it that people don't realize, is that the disease, which is the sense of discomfort, which underlies their reasoning for picking up and using a drug in the first place, is independent of their use. So if they sit there and they say, I am now in recovery, I have not used opiates or alcohol or any other drug in 2 years, 3 years, 10 years, 20 years, right? If 20 years go by and I start using, my disease will immediately be at the point that it would have been if I had been using for the past 20 years. It will be 10 times worse than it was 20 years before the last time they used.
Oh,
So it's awful. It leads to calamity right away instead of to after a month or a year of use. And they sit there and say, how is that possible? I suddenly felt as if I was where I had been, when I stopped last time rather than when I first started, which is what I thought was going to happen. Because that's just getting worse. Doesn't matter that you weren't using.
well, what percentage of your patients do you have that go on buprenorphine versus don't and just work through issues while stopping whatever their drug of choice was?
The tendency for folks is to not come to a psychiatrist or an addiction specialist, physician anyway, unless they're going to start on the medication.
Okay.
Because usually they can see a social worker or another clinician less expensively, who's not going to be prescribing them. So it's I'm sort of automatically biased because everybody who comes to my office for treatment of opioid use disorder is coming on the basis that they're going to be able to get the medication for it.
Okay, yeah, that makes sense. Do you have a feel for how many of your patients have successfully stopped the buprenorphine and gone on to be successful?
Very few. Very few. I'd say in the past 14 years, I've only had 3, maybe 4 patients out of 1,000 that I've treated, over the course of the years, who stopped the medication and continued to do well. The others who have stopped, there have been many who have tried, inevitably come back, sometimes a month later, sometimes a year or 2 later, and say they'd like to restart. They're feeling the craving come back. They're feeling that, usually it's that things have gone wrong in their life. Their spouse left them. Their house had a house fire. They didn't have a place to live for a while. Their dog died. It could be anything. Whatever it is that triggers that feeling that I can't deal with this and I need an out. That's the right time for them to come in. But I've had a few people who've successfully come off and stayed off. They've worked really hard at their recovery program along the way.
Okay. And how about how many patients have stayed on, but at a very, very minimal dose and they've been successful just with that?
A handful of those patients who've done well on 1 or 2 milligrams.
Okay. Okay. Does that 1 or 2 make a big difference, or is it mostly just to avoid the withdrawal issues?
I don't know whether it's what you're asking really is it in their head, right? Is it just that they feel better with the idea of I'm relying on a pill rather than on myself?
That, or the therapeutic effect versus I just don't want to tackle the full withdrawal. I just don't have it in me to go through that.
Might be. I mean, you're asking the right question. I don't know that I really push my patients to figure that out.
Sure.
I think, my goal is to get it so that they have their function back in life, typically so that they have their work and their family and some money in their pocket and, a life that lets them do the things that they want to do.
Sure.
And if they're doing that, I view that as a success and don't really try to bore down too much on how exactly in their head they've gotten there.
Yeah. No, that
You know,
makes sense.
the vast majority of folks stayed at the 16 milligrams,
Okay.
and just did so over the long term. And yes, they had you know there were some complaints of constipation. There are some complaints of the other typical annoyances of having to take a medication every day.
Okay.
But beyond that, it as medications go, it's not unreasonable.
Okay. And fully functioning cognitively, like, would you be comfortable sending somebody into the healthcare setting on 16 milligrams a day and they're at the bedside taking care of patients?
Most states won't allow that. There's rules in place at various either the state level or the local level about that. Wait, I ran into that a few times with a city employee who was on methadone years ago and had absolutely no side effects from a cognitive standpoint and was doing his work. But he knew perfectly well that he would not be allowed to work if anybody knew that he was taking methadone.
Yeah.
We have commercial truck drivers. They're not allowed to take Suboxone, but the CDL, the drug checks that are done for them don't include Suboxone. So they'll often come in and specifically not tell us that they're commercial drivers. So you might find that out years and years later, usually after they've left. But it's not. People are very secretive about that.
Right. Aviation too, right? Pilots.
As well. I haven't heard any specific cases of that, but the FAA doesn't allow pilots to come back if they're taking buprenorphine.
Okay.
But again, if you were on a stable dose of buprenorphine, you would not be cognitively impaired, and I suppose a pilot might one day argue that case.
Okay. All right. So there's assessment tests, right, that you can do before people return to work. And so I imagine you've been involved in those. You find that they're fully functioning on a stable dose.
Yes.
Okay.
Yeah.
Okay. All right. Well, this has been interesting. What would you say is the main thing, or what discussion do you have with your patients when they're making the decision of whether to go on this or not, and what their treatment is going to look like? What are the main things you think they need to be aware of?
Usually the discussion is quite advanced at the beginning because typically the patient's already bought the Suboxone on the street. And that's the interesting thing about this particular medication is that it's a controlled substance and they're not allowed to buy it on the street. And yet they do because that has been their typical way of buying drugs.
Everything. Yeah.
And so, they go to the same resource. It's inexpensive. They don't have to drive a great distance and they get it any time of day. And so when they come to me, it's usually with, they look sheepish and say, well, I've been taking this and I would like not to be buying it that way, using it that way. I'm not sure what I'm getting. I'm not sure it's always, legitimate. And I'd like to try and fix this. And I say, okay. But they already know what the side effects are because either they have them or they don't have them. We talk about that. I talk about, how long they may have to take it and what they took it for and what their purpose is. Sometimes they'll come in and say, I'd like it so I don't have to use heroin every day. I'd like to have a choice of using this some days, and then maybe if I really want it, I'll use the heroin. And I mean, they're negotiating, right? It's a sense of loss. I'm not going to be able to do this anymore, and I view it that way. And I say, all right, as a negotiation, this is a step in the right direction.
Right, it's their own taper.
But we're not going to stay in this place for long.
Right.
And no one ever stays in that place for long, but it is a waypoint on the course.
Interesting. Yeah. So you take what you can get at the beginning and you let them work their way. I would assume you have contracts or some sort of understanding. It's like, all right, we'll start that way, but this is the goal of where we're going to get.
Right. We get to the point where, we do urine drug tests to monitor. It's not meant to be punitive. It's simply there the way if I were treating you for your blood pressure, I would check your blood pressure each time. And if it's high, I wouldn't say, oh, you've been bad. So it's the same thing here. If somebody comes in and they have a positive urine drug test, I say, well, it looks as though your illness has sort of gotten the better of you this last week. How might we approach things over the next week so that it won't?
Right.
What can we do differently? So some programs might throw them out. Some programs still have this sense of, well, I can't treat them unless they're clean and sober. But you have to meet patients where they are, and they are not always all better when they first start. They're usually not.
Sure. Yeah, I'm sure they're not. Yeah, it's a process. Okay. Well, this has been great. This has been really informative, and I appreciate you taking the time to kind of break some of this down for me and for the listening audience.
Sure. Well, thanks so much for having me. I look forward to hearing the comments.
Thank you, Stu.
Good to see you. Take care.
You too. Bye.